So we are here today with Professor Michael Gnant, and we're really excited to talk about ASCO and the advances in breast cancer that were presented at ASCO 2023. Professor Gnant, could you perhaps give us a little understanding of your research interests and perhaps a little bit about your career so far, and then we're going to dive straight into ASCO.
Yeah, thanks for having me, Phil. I'm a professor of surgery, surgeon by training, with a particular interest in surgical oncology, and recently narrowing down on breast cancer. I'm also coordinating the Austrian breast and colorectal cancer study group that has been able, from our small country, but because we have so wonderfully great patients who in large numbers contribute to our prospective trial, more than 30,000 so far in the last 3 decades. And that gives our tiny country the opportunity to contribute a little bit more than we are in terms of geographical size to the knowledge, with a focus on endocrine treatment in early breast cancer, which is also one of my main research interests, but we also are doing a lot of research in neoadjuvant trials, as well as some specific issues such as PARP inhibition, bone-targeted treatment, and so on.
Super. Thank you so much. And if someone wasn't able to make it to ASCO this year, what was everyone talking about with regards to advances in the management of breast cancer? What were the kind of key takeaways, the key papers that you think we should know about from your perspective?
Well, ASCO 23 in terms of breast cancer was pretty much focusing on the NATALEE trial. To give you some background, there's a relatively new class of drugs, so-called CDK4/6 inhibitors, cell cycle inhibitors, that in recent years have become standard of care in hormone receptor-positive metastatic breast cancer, actually first-line standard of care. And there is, in fact, a total of 4 of them. One, talbociclib, is a Chinese compound that may not arrive in the European or US markets. The other ones, palbociclib, ribociclib, and abemaciclib, have been tested in various large clinical trials in metastatic breast cancer, first line, second line. Having said this, as always, we are trying to transfer advantages and benefits we define in the metastatic setting to the curative breast cancer setting. And there have been interesting but also controversial results, because 2 large palbociclib-based trials, the PALACE trial and the Penelope-B trial, have been negative. So palbociclib in the early breast cancer setting so far did not demonstrate a benefit when added to standard endocrine treatment. And quite differently, abemaciclib has, in the MONARCH-E trial, now at the median follow-up of 4 years, shown a consistent benefit. In fact, that amounts to an absolute 6% benefit approximately in disease-free survival. Data were missing for the third, for ribociclib, and suspense was increased because, as obliged by the stock market in change rules, there was a press release a couple of months ago that the NATALEE trial, which is testing the addition of ribociclib to endocrine treatment in the early breast cancer setting, would be positive, but with no details. And that was actually the first and probably most discussed presentation in the field of breast cancer. To make a long story short, NATALEE has demonstrated benefit overall at the very early stage. So this is still an interim analysis, with 4 out of 5 patients still being on trial treatment. So one cannot call this robust at this time, but interestingly, even so early in the trial, There's a clear benefit basically among all subgroups that include a little bit more of the risk spectrum that the monarch-E trial had included. So it's not only highest risk patients, but also moving CDK4/6 inhibitors into the, let's say, intermediate risk group. Now, that early, so that's exciting. It's good news for patients, and it could, if confirmed, it could, let's say, extend the target population of that additional treatment from the highest risk subgroup of patients to maybe a total of 35% of all patients with hormone receptor positive breast cancer. However, because that was the presentation of an interim analysis, everything correct in terms of the statistical conditions, but the number of events, particularly in those lower risk intermediate subgroups, is still limited. So many of the discussants, and I would agree with them, advise caution, because these results need to be confirmed by updates with more follow-up, more events coming in. I'm convinced NATALEE will update their results more or less at every major meeting in the field of breast cancer now in the next couple of years. Also, we have to say, with a relative improvement of disease-free survival by about 25%, that obviously makes a difference in terms of the absolute benefit wherever you are in your risk situation. So such a 25% improvement sounds a lot, but because of the excellent overall results we meanwhile achieve in the treatment of early breast cancer, this might be 4 to 5% in patients at very high risk, but it might only be 2%, for example, in node-negative patients. And that's a 3-year treatment duration with an additional treatment. And so discussions will obviously be, how much of an absolute benefit do we as scientific community, but also the regulators, and more importantly, eventually the payers, request for what can also be interpreted as a small benefit, because obviously when you have 2% of absolute benefit, you treat 98% of patients without them benefiting, and these drugs are not particularly cheap. So not only in countries with limited resources, but also, I would say, in average countries in the Western world, there will be some discussions about approval, reimbursement, and who really should get the additional treatment.
It's super interesting and really interesting to kind of see the pace at which we're moving in this space. If we were looking at ASCO 2024, what do you expect us to begin to see coming out in terms of results, and what do you think are the biggest or hottest ongoing trials in breast cancer right now?
Well, I think one of the interesting things is that for almost 2 decades, there was not too much innovation in endocrine therapy. And in fact, with hormone receptor positive breast cancer being the most prevalent subtype, actually the largest number of breast cancer patients around the world is affected by potential advances in hormonal treatment. Now we really see an explosion of innovation. So after 2 decades of more or less using and optimizing all the drugs we had, we are now seeing the CDK4/6 inhibitors coming there. We see a complete new generation of oral SERDs that are moving into large clinical trials, even in the adjuvant setting. And even beyond that, I mean, there were some interesting posters on new type of drugs, so-called PROTACs or SERANs, complete estrogen receptor degraders that will have to be tested. So there's really a lot going on. It's difficult to predict what might be available in 24. But there is one overarching theme, I think, and that's our current standard of care is aromatase inhibitors. These drugs are generic, so I wouldn't exactly call them penny drugs, but I mean, this is about the monthly treatment cost of 10 to 20 pounds, euros, bucks, more or less, and substituting them with drugs that at the moment have monthly cost of 3, 4, 5,000 is a huge challenge, particularly because such a large number of individuals is potentially affected by that. So that's going to be a huge discussion. The question is, can we somehow better define on an individual basis using biomarkers, using predictive factors, who really has a sizable benefit, because it might not be very likely that we will be able to afford these treatments for everybody, not even starting to talk about countries with limited resources. And one interesting technology that I think will, I'm very optimistic that will prevail, other than some other attempts in the past. For example, when we were trying to hunt down circulating tumor cells, that technology never really, there were some interesting reports, but it's so difficult to define it. But there is now a technology that is increasingly used also in the context of clinical trials, and that's the measurement of circulating tumor DNA. And that's both interesting in the high-risk segment, so let's see in patients with large tumors, neoadjuvant treatment, to see, because we can actually find circulating DNA stemming from tumor cells in the majority of these high-risk patients, and we can monitor how our treatments are providing clearance of this circulating tumor DNA, and that has been already shown to be a predictive factor also for long-term outcome. On the other hand, in particularly in luminal breast cancer, we are still, with all the advances and excellent prognosis overall, we see the issue of late recurrences. So whatever might have been written in old books, after 5 years, if you remain healthy until then you are fine. That's simply not true for hormone receptor positive breast cancer. So while these patients overall have an excellent cure rate of 85, 90%, but there is a constant prevalence of late recurrences, maybe 0.5% per year. But in 20 years, that also amounts to 10% of all patients. So it's still a little bit a mystery how that works in terms of the cancer biology behind. I think the most common understanding is that micrometastases can go to a dormant state and eventually wake up and cause weird clinical recurrence. And identifying this early, and the technology I was talking about, circulating tumor DNA, apparently is able to identify a patient that will have clinically overt recurrent disease with a lead time of about even 12 months or so, which in theory gives enough time to intervene. Now, having said this, we still don't know, but these trials are starting now or have been started now around the world, whether we can intervene in a situation, because the diagnostic alone, I mean, if you have a patient and they say, yes, Ms. Miller, we found circulating tumor DNA in your blood, and then Ms. Miller will ask, so what are we going to do about this? Unless we can demonstrate that we can successfully intervene in such a situation, it's still a theoretical research theme, but it's not unlikely that we might be able to define interventions at this point, more or less keeping the disease at bay, keeping these cells sleeping, so to speak, providing clinical disease-freeness. So that's probably the hottest topic, so to speak, and I would expect that in the next couple of years we're going to see very interesting results around this subject.
Absolutely fascinating. So we're talking about early treatment, keeping the disease at bay, and actually thinking about the earliest possible intervention for patients when we find that they're at risk. Really interesting. Thank you so much for your time, Professor Gnant. We really appreciate that summary of the hottest topics in breast cancer from ASCO 2023, and a little glimpse of what's going to come in the next couple of years. Thank you so much.